Good day everyone, this is Dr. Chee-Wee. Today we're going to explore the measurement of physiological range of movement. This is the first of two videos, and in this video we'll be looking at the procedures for measuring joint ranges. In our second video, we'll look at the measurement properties of the equipment. Before we start, let's have a look at the aims of this week's session. By the end of this week, you should be able to apply the principles relating to the measurement of physiological range of movement. Although the aims says that this is specifically to the lower limb, these principles apply to all regions of the body as well. You also understand the importance of consistency in the measurement of joint range and be able to critically evaluate the factors that contribute to the reliability and validity of joint measurements. In terms of skills, you also learn how to use a goniometer proficiently and how to record your findings. As you have observed, physiotherapists perform a lot of joint movements during our interaction with our patients. The purpose of this is to take a baseline reading of the current condition of the person. This will also allow us to compare for future improvements or deteriorations similar to other outcome measure evaluations that we looked before. Based on these readings and their comparisons, we can plan and progress treatment as well as monitor it. Joint range of motion measurement is one of the core skills of physiotherapists. Research on this topic goes all the way back to the mid-20th century. Due to its long history, we now have published population norms of joint range of motion values stratified for both age and gender. When we measure a joint range, there are some considerations that may affect the manner in which we approach our evaluation. The very first thing we need to consider is the type of joint you're trying to measure. The configuration of the joint will determine the manner in which we organize our measurement. For example, a hinged joint like the elbow will be easier to measure compared to the multidirectional shoulder joint, which is a ball and socket joint, by the way. Next thing to consider is the purpose of your measurement. Are you measuring baseline readings, monitoring your treatment progress, or for conducting a piece of research on your patient population? In the context of your joint measurement, what is the most appropriate instrument to use? Does the approach need to be easy to administer? Do you require a more accurate and precise method of measurement because detecting a slight change in joint range is absolutely crucial in what you're trying to do? Of course, we need to take into consideration what we currently know about the measurement properties of the instrument itself. Lastly but not the least, we'll need to choose a test position that is most appropriate for the patient being measured, bearing in mind that certain patient populations can't tolerate a number of body positioning. So we may have to alter the testing position to accommodate this. In terms of the variety of joint range measurement instrumentation, there are many methods that physiotherapists can choose from. Some are used more often than others because of convenience, with the compromise by acceptable loss of precision. Even with the use of visual estimation, that's using your eyes to gauge how far the joint has gone, if you're only making rather crude measurements, it is actually rather accurate to about within 5 degrees of movement. Let's now focus on the universal goniometer and its features for joint measurements. Shown here on a screen is a universal goniometer. It has several features. Firstly, there is a stationary arm with no measurement markings on it except for a bisecting line. You'll be using this arm to align it with the usually static upper region of the joint. Now the next feature is the moving arm with measurement markings on it and a bisecting line. As you rotate the moving arm, the bisecting line will point to an angle on the body with the goniometer indicating an angle. The moving arm follows the moving distal region from the joint. The third feature is the fulcrum or axis. The axis is placed at a joint at a point where the joint is rotating. The landmarks for placing these three features are predetermined. You can obtain these landmarks in goniometry guide, or you can search online for them as well. The landmarks can differ between sources, so always record it in your notes, the landmarks that you use for joint measurements for consistency, and in case a colleague of yours has taken over your patient and needs to follow exactly how you measured the joint angle. Let's now use the example of the knee range of motion to illustrate the use of the universal goniometer. You can measure knee range in two positions, either in supine or in prone. So position your patient in the most suitable position. Now, let's determine the landmarks for alignment. The landmark for the stationary arm, according to Norkin and White 2016, is the lateral midline formed by using the lateral epicondyle of the femur and the greater trochanter. The landmarks for the moving arm is the lateral midline formed using the lateral malleolus near the ankle joint and the fibular head on the lateral aspect of the leg. The axis of rotation where the axis of the goniometer will be placed is located on the lateral epicondyle of the femur. So once the arms and axes have been placed on the appropriate landmarks, the joint is moved through its maximum range, after which the moving arm is repositioned to the new position of the landmarks and the angle read of the goniometer. Throughout the process, there are some things you should keep in mind. Firstly, are you measuring the active or passive range of motion? Both range of motion will have slightly different ranges, with the passive range usually slightly smaller than the active range. Sorry, it's the other way around. It should be the active range usually slightly smaller than the passive range. Now this is due to the slight elastic stretch of the relaxed muscles during passive range of motion. Now the second point is important. Always explain the purpose of the procedure in layman's terms. This is for informed consent purposes and also to make the task easier. As we mentioned before, not all patients can tolerate the positions you want them to be in. Therefore, you may have to alter the positioning in order to accommodate this. This may also change the location of the landmarks, so just be very aware of that. The next point is a common mistake made by novices. The proximal region a lot of time needs to be stabilized properly. Otherwise, the joint angle measured will not be accurate. Lastly, always demonstrate to the patient the movement you'll be performing so that they are comfortable with it. After you made the measurements, it is essential that you record your findings in the notes. First, note down what type of ROM you've performed, active or passive. Next, record the starting position and write down what position the patient is in and what landmarks you've used. Lastly, write down the range. There are various ways of recording joint range. You can write down the starting and end range angle, or write the movement and the angle achieved. It doesn't matter which way you've written down the angle, joint angle, so long as the person reading it is able to understand it. The type of joint measurement we've mentioned above involved static joint ranges. It is also possible to measure dynamic joint range. Now this involves more sophisticated equipment and are usually too expensive for everyday usage. Examples are the use of videography and photography, electrogoniometers, and imaging technology. We've now reached the end of this first video on measuring joint range of motion. In our next video, we'll look at the measurement properties of goniometry for measuring joint range. So I'll see you at our next video. Bye.